In, we will start our session. Yes, it started now. Okay. Before starting our fourth session, we had a one question in previous session. It was about osteoporosis and breast cancer. Uh, One of you was saying that we give tamoxifen, but I searched, and this is from therapeutic guideline. It is written here that first of all, if patient has osteoporosis, diagnosed osteoporosis, even in breast cancer, you will give bisphosphonate or denosumab. Okay, any of these, if the patient has first line is bisphosphonate and denosumab. But if there is no option for this, or patient is already taking it, and you have to prescribe hormone replacement therapy, and you are going for tamoxifen, then tamoxifen can also be given. But tamoxifen is usually it stabilize or increasing mineral density is in just postmenopausal women. So you have to pay attention to this point also. In postmenopausal women, you can give tamoxifen. But in premenopausal women, you don't prescribe tamoxifen because it leads to bone loss. So this was one question which was left from the previous session. Now we will start this questions we have for today. Okay. This is a question. A 7-year-old boy is brought by his parent because of concerns about his school performance. He frequently interrupts the class and is easily distracted. He has trouble finishing homework, loses twice frequently. These behaviors occur both at home and school. His past medical history is unremarkable and growth and development are normal. According to you, what is the diagnosis of this patient? It is ADHD. We have a lot of where you can read about ADHD. In JM also you can read. If you have another sources for psychiatry like Kaplan, you can study from there as well. I have mentioned some slides for from therapeutic guidelines. I will show you right now. So according to me, Kaplan is a good resource. But if you feel that it's very extensive or you cannot you don't have much time to complete all of it, then just look at John Murtagh, because John Murtagh is also explaining typical points only. But Kaplan is very good for psychiatry. This patient has ADHD. How do you know this patient has ADHD? Because of the symptoms. He interrupts the class, very important, okay, which is given in the history. He loses his twice frequently, and here there is no developmental problem. Okay, diagnosis is clear. Previously, we had a one recall in which the patient was same like this patient, very typical case of ADHD. They were asked what you will do first in the management. In that recall, the question was in the question, it was not given that it occurs in two places like both home and school. In history, this was not given. So the option was we will take collateral history from parents or from the teacher. If it is happening in the school or teacher is complaining, then collateral history should be taken from parents. Or if it's at home, then we should take history from the school, from the teachers. This was the recall, and it is necessary for the diagnosis. Okay. This is the guidelines, what the guidelines are saying. You can use RCH as well. I am explaining this that previously in this is the recalls from the recent months. The in previous recalls, previous year recall, we had a one question in which patient was having these symptoms of ADHD, and they mentioned it was either in school or home. So I'm saying in that recall, the option had that we will take the collateral history from the parents or from the teacher. I'm saying that present this point. The symptoms should be present in 2 or more settings. This is important. You have to look for this. You cannot make direct diagnosis. So in that question, the option was you will directly start the treatment. There was 4 5 treatment. You will give CBT, cognitive behavioral therapy to the patient. You will go for counseling. You will start medical treatment, or first you will take history from parents. So I'm saying first you will go and take history from parents. This is the criteria for ADHD. This is diagnostic criteria. What is required? Number one, more than or equal to 6 symptoms of inattention or hyperactivity or impulsivity. This is necessary. Present for more than or equal to 6 months. In a lot of psychiatry questions, you will not have this, that these questions, symptoms are present for 6 months. A lot of places, they just mention that patient is presenting with this symptom, this symptom, this symptom, and now what you will do or what's the diagnosis. Very few questions recalls I saw where they are mentioning about the months or duration of the symptoms. It is a must that it should present in 2 or more settings. Onset is mostly before 12 years, because if you know that ADHD, then after in adulthood, mm, we don't call it ADHD. Next is causing impairment, not explained by another condition. This is also important. There is another question, another recalled in previous years, that we will start the stimulants. There were stimulants mentioned, but it is very important point that GPs in Australia cannot prescribe stimulants. Okay, we have to refer the patient to the specialist or psychiatrist. They will start the stimulants. GPs cannot start the stimulant. Okay, so this is also important. First line management for ADHD is non-pharmacological. We will have counseling, training, behavioral therapy. After that, we will prescribe pharmacological therapy. Pharmacological therapy, as I said, is started by a specialist. Stimulants, what is the first line medical treatment is methylphenidate. Okay, this is the treatment of choice for ADHD. As we already know, EEG, MRI, they are not required unless patient has atypical features such as seizures or regression or other neuroscience. Okay, I have this. You can read this from therapeutic guideline as well about ADHD. This is the again criteria. What criteria is required for the diagnosis of ADHD? Symptom must be present before the age of 12 for at least 6 months in 2 settings. Interference with social or academic function, as our patient had school performance, he was not finishing his homework as well. Do not occur exclusively during the course of psychotic disorder and are not better explained by another psychiatric disorder. Not functional disorder, not psychiatric disorder. Non-pharmacological treatment, we have social and organization skill training, cognitive training. Remember, this is the first line treatment. Non-pharmacological treatment is the first line. If it fails, then we will go for second line treatment. Cognitive training, parent behavior timing, okay, classroom management measure, these all are done, and then we will go to pharmacological therapy. Here it's written again, this point, this can be asked as a question also. What is the first line treatment? First line treatment is non-pharmacological. Okay. If you want to go for pharmacological treatment, then stimulants are the first line treatment, like methylphenidate. Next are other atomoxetine may be used if stimulant cannot be used or is not tolerated. Okay, or when there is comorbid such as Tourette syndrome or severe anxiety disorder. It's better to just memorize that non-pharmacological is first line therapy. What is the diagnosis? Below 12 years, within symptoms should be within 6 months, and it should be in the 2 settings. And if you want to give the treatment, pharmacological treatment, stimulants are first line drug of choice, and these cannot be prescribed by a GP. For this, specialist is required, and Among the stimulant, methylphenidate is the first line choice. Okay. Just this much is enough for ADHD. For all the psychiatric disorders, diagnosis, you should just know the diagnosis. Diagnostic criteria is very important along with some symptoms. Like for this question, for ADHD, they can also give you just about what impulsivity. If just impulsivity is given and other symptoms you don't know about other symptoms, you can diagnose ADHD. Like for autism, they have repetitive behavior. This is very typical. So you should just, if you don't remember whole criteria, just go for these specific symptoms. Okay. What is the next question? Next question is a 42-year-old woman present with 3-month history of intermittent bloody discharge from her right nipple. She has no breast mass, pain or lump, no palpable mass, and no axillary lymphadenopathy. What is the most likely diagnosis? So what is your most likely diagnosis? Intraductal papilloma. Okay, ductal papilloma. Dictasia, ductal. Okay. But we have at least 2, 3 of you told the differential diagnosis as well. So we will go with when it's most likely diagnosis, you should go first for the most common pathology for unilateral nipple discharge or breast discharge. It is interductal papilloma. It is the most common cause. Duct ectasia is a differential diagnosis, but most when they are asking about most common or most likely diagnosis, it's intraductal papilloma. Intraductal papilloma is unilateral, bloody nipple discharge, and there is no mass, no palpable mass. Okay. But duct ectasia, if they will give you duct ectasia, I have seen the questions, they are not giving bloody discharge. What I have seen, they are giving green discharge for ductictasia. This is also common, but it's not the most common cause. Intraductal papilloma is the most common cause. Next is breast carcinoma. Breast carcinoma can present with nipple discharge, but it's very rare. We might think that, oh, breast cancer, if patient has breast carcinoma, then they will have nipple discharge. No, it's rare. It's not impossible, but it's rare. But most common cause is intraductal papilloma. Also for breast carcinoma, you will feel some kind of palpable mass in the breast. Okay, I have already opened this. This is an RCGP article. RCGP article. In this article, you can see different causes of nipple discharge, and what is physiological nipple discharge and what are the disorder of the nipple. Okay. When is the nipple discharge abnormal? Spontaneous nipple discharge unrelated to pregnancy or breastfeeding is considered abnormal. In most cases, it has a benign or non-cancerous cause and is more likely to be unilateral, confined to one duct and clear or blood stain in appearance. So this is the mostly it is benign, mostly unilateral from one duct, and it can be blood stained or it can be clear. This is duct ectasia. Duct ectasia is a benign condition in which there is enlargement of milk duct under the nipple with inflammation in the wall of duct. It usually occurs in women after menopause. Okay. Discharge is usually bilateral. In our case, discharge is unilateral. It is yellow, clear, or green. See, if you see here, they have not mentioned bloody. It's mostly usually bilateral and it's yellow, clear, or green in appearance. And it doesn't require any treatment. Duct papilloma or intraductal papilloma, which our patient had, is a growth within a milk duct in the breast, usually near the nipple. It may cause no symptom or discharge that is clear or blood stained. Ductal papillomas are also benign or almost always benign. Very rarely they may be associated with breast cancer. Other disorders of nipples are nipple eczema, breast cancer. Breast cancer is an uncommon cause of nipple discharge, as I've already told you. Other recall we have a recall where we have Paget disease of nipple as well. Okay, this is a benign breast cancer involving the milk duct. It typically causes a blood-stained nipple discharge with ulceration. This is very important. This, if patient has Paget disease of nipple, it will have bloody discharge with ulceration and erosion of the nipple. Okay, so these are the causes of nipple discharge abnormal. It could be ductal ductal papilloma, nipple eczema, breast cancer, Paget disease of nipple. Hormonal causes can also be the cause. Drug and medications can be cause of nipple discharge. Treatment depends upon the cause of the nipple discharge. Mostly, it doesn't require any treatment. One important thing here is if there is a spontaneous, persistent nipple discharge that is unrelated to pregnancy or breastfeeding, you need what? Imaging. After examination, you need imaging of the breast with mammography and or breast ultrasound. So in our patient, we saw they asked about the most likely cause. Okay, most likely cause is diagnosis is intraductal papilloma. Even if you suspect intraductal papilloma, it is unilateral, it is benign. Still, what you will do mammography or ultrasound depending upon the age of the patient. Okay, so this is important. Sometimes sample is sent for the discharge and fluid is sent in the lab, but it has no relation. Okay. For some kind of nipple discharge, surgery is needed, such as for papilloma or breast cancer. Okay. For ductal ectasia, we have a recall in which ductal ectasia treatment they asked, it has no treatment, okay? No specific treatment. Another article, wait, this is from RSCGP. This is also from RSCGP about management of benign breast condition. It's similar to the previous article, so I have mentioned here. This table is important. Causes of abnormal nipple discharge. Ductal is the number one. A benign condition, not number one, not most common. Most common is ductal papilloma. A benign condition with dilatation and inflammation of ducts under the nipple usually causes a bilateral, very important, this is bilateral, yellow, green, or brown discharge from multiple ducts. This is also important that it is from multiple ducts. Ductal papilloma, on the other hand, is typically causes a clear or blood-stained discharge. Papillomas are usually benign, may rarely lead to breast cancer, and these are surgically removed. So we already saw that blood-stained discharge and papillomas are usually require surgery, but duct ectasia doesn't require surgery. It heals on its own, resolve on its own. Other causes are nipple eczema, breast cancer, which is a rare cause, Paget disease. This is also blood stained, but it has ulceration and erosions. Okay. Hyperprolactinoma can be another cause, but that is galacturia. It's milky discharge. It's not blood stained. Okay. Again, the management depends. If you want, you can read this whole article. It's not necessary to read all. Okay. For the nipple, you just remember this nipple discharge. Okay, this is another article from Cancer Council, I think, where they are asking when you need surgery. Okay, surgery for nipple discharge is sometimes required. As we have already read, surgery where it required total duct excision and single duct excision. These are two types of excisions, which are surgeries which are performed for nipple discharge. Total duct excision is required when we need to remove all of the ducts immediately behind the nipple. This is suitable for women who do not intend to breastfeed or when more than one duct could be the problem, like in duct ectasia. But in duct ectasia, It's multiple duct, but it usually doesn't require surgery. Single duct excision, this involves removing a single duct. It is only able to be performed when it is possible to identify a single duct as the cause of problem. So first you should identify that a single duct is the problem, then you can remove it. So both of these articles I have mentioned, I have added in the slides, the link, so you can read it. Here again, I have mentioned that ductal ectasia, this is also benign, mostly in perimenopausal. So these things you should remember about. For example, this patient was 42-year. If they will give you duct ectasia, age should be around 45, 47, I think. Perimenopausal, okay? The discharge will be bilateral, not unilateral. And most probably they will give you discharge of green color. This is I have seen in previous recall. They are giving green color discharge and management is reassurance. These are the links, so you can read from here. This I have already said. Next question. Okay. Next question is a 22-year-old university student present with recurrent painful blisters on her lips. They begin with tingling, then develop into vesicles that crust over within a few days. She is otherwise healthy. Which of the following is the most appropriate management for this patient? A. What is the diagnosis? Those who said A or C, can you tell me the logic behind it? You were right. Because patient has viral illness, we will go for reassurance and supportive care. But this patient has recurrent. Okay, this patient has recurrent painful blisters. Okay, this is not the first time she's presenting. She's otherwise healthy. Good point. If she had not recurrent painful blisters, then we will go for reassurance and supportive care only. But why? Because this patient is coming with recurrent painful blister, the answer should be oral acyclovir. One of you said D, because this is a viral illness, this is HSV, antibiotics have no role, okay? So this is viral illness. We will go with acyclovir. I have mentioned a lot of options for you. Question can be from different treatment. Okay. This is the most simplest treatment for cold sores or herpes simplex or herpes labialis. First is it is from John Mortag, but I have mentioned ahead from therapeutic guideline. Therapeutic guideline have explained it for each person like immunocompromised, immunocompetent, mild, moderate, severe. So if first of all we will go with the simplest one. Simplest one is from John Mortag. It's saying that if patient is presenting with first sensation of the development of cold sore, we will give topical acyclovir 5 times daily. Okay, for 5 days it's given. Acyclovir cream for 5 times of 5 days. Why I'm saying that it is important to go from here because in therapeutic guidelines they have not mentioned that first line treatment is topical acyclovir or topical antiviral. But in John Murtagh it's written that acyclovir at first presentation we are giving acyclovir 5 times daily for 5 days, or we are giving famciclovir orally single dose. Corticosteroids have no contraindicated. If we want to give oral medication, like in severe primary attack, then acyclovir 400 milligram 5 times daily for 5 days is given. Or acyclovir orally or famciclovir or valacyclovir single dose orally. So this is the treatment from John Murtagh. Now we will go for therapeutic guidelines. So therapeutic guideline is more updated, so we will go with the treatment of therapeutic guideline. Okay. This is management of mild. This is the first initial episode of cold sores in a patient who is immunocompetent. So for immunocompetent patient, what we will do, supportive management, which one of you already said that if it's first presentation and it is mild, go with supportive management. Supportive management is hydration, antipyretic, anti-analgesic. Oral antiviral therapy is usually not required, and they have not mentioned anything about topical acyclovir or antivirals. For mild initial episode of oral herpes, what they are giving, topical anesthesia. Again, it comes in supportive management. Hydration you will give, antipyretic you will give, analgesic you will give. Analgesic is topical. Anesthesia, benzodiazepine, 1% gel, or if you cannot give that, then you can go with lidocaine solution. And if it depends upon the age about the treatment, you should not, no need to memorize it. Just know for mild initial episode in immunocompetent patients, you will give supportive management. In supportive management, if they haven't mentioned supportive management, but there is a topical anesthesia, either benzodiazepine 1% gel or lidocaine solution, go with this because this is what's mentioned in therapeutic guideline. Next is if a patient is presenting first initial episode, but this time the patient has severe presentation, maybe multiple lesions, or patient has fever, unable to swallow, unable to eat, okay, very painful. At that time, what you will do? Here, treatment is oral antiviral therapy. Okay? If patient is presenting with severe initial episode, go with oral antiviral viral therapy. What is the antiviral therapy they are recommending? Famciclovir orally for 7 days, valacyclovir for 7 days, acyclovir 5 times daily for 7 days. This is the difference from John Murtagh. John Murtagh was saying that single dose of famciclovir or valacyclovir, if acyclovir, it was for 5 days. Here the dose is different. Sorry, number of days is different. So duration is different. Memorize this. If the patient has severe initial episode in immunocompetent, we will go with oral, and oral is acyclovir for 7 days, valacyclovir, famciclovir for 7 days. Okay. Um, Okay, this is also another important point here, that therapy treatment just reduce the duration of symptoms, okay, by 24 hours, but does not appear to diminish recurrence. If patient might have recurrent herpes or cold sore, it doesn't decrease the recurrence. It will just improve that initial symptoms or that time symptoms. Duration of symptoms will decrease. Okay, this is also one line they have written. If the patient is unable to swallow, refer to specialist advice for IV antiviral. Okay, we will give IV antiviral if patient cannot swallow. Now we are coming with patient with recurrence of oral, like our patient. She had recurrent, she had mild, but it is recurrent. What they are giving? In this case, what they are giving is acyclovir. This is the treatment what is mentioned in John Mutta. Immunocompetent patient with mild recurrence of oral mucocutaneous herpes, episodic antiviral, okay, because this is recurrent, we will give episodic antiviral therapy, okay. First sign of the recurrence, at the first sign, start what? Acyclovir topical treatment. If you cannot give acyclovir topical, then go with famciclovir orally. This is for recurrence. But in our question, we didn't have option of topical acyclovir, so we choose oral acyclovir, okay. But if there will be topical, we can go with topical also. Next is severe. It is same as severe recurrence is same as severe. You will go with famciclovir, valacyclovir, or acyclovir. You will give orally. Oral treatment is given here. Just memorize. Just remember this, that topical treatment, topical acyclovir we are giving when patient has recurrent mild herpes. If it's mild herpes without recurrence, just rehydration or supportive treatment is given. If it's severe, then we will go with oral antivirals. This much, if you remember, it's enough for you. Now, this is also important. What is this? It is immunocompetent. It is frequent and severe recurrence in immunocompetent. Very severe. At this time, the dosage is increased, duration is increased for 6 months because it is severe and it is recurrent. Even patient is immunocompetent, then you will give the antiviral therapy for 6 months. Okay. So in summary, just you recurrent, if patient has recurrent or patient has severe, you will go with oral antiviral. If it's severe and it frequently recurs, duration is increased to 6 months. Dose is not that much important, but duration, yes, because a lot of time, not for all, but just go once, keep this in your mind that if it is very severe or it is uh, very frequent, then duration is increased for 6 months. Otherwise, we are giving for 5 days or 7 days. This much, if you keep in your mind, it will be good for you. Otherwise, dosage, I myself haven't memorized dosage except when it was very specific. Okay, next questions. Oh, one more thing in see, they can give you picture as well. So see the pictures of herpes. I think everyone can diagnose these. This is vesicle crusted. It can present as this vesicles, pus filled. This is different stages of herpes. Some are healed, some are ulcerated, crusted. So they can give you just these pictures as well. Okay. Next question. A 3-year-old boy presents with 5-day history of high fever, not responding to paracetamol. On examination, he is irritable and has bilateral non-purulent conjunctival injection, cracked red lips and a strawberry tongue, erythematous rash on the trunk and cervical lymphadenopathy. Which of the following is the most likely diagnosis? Yes, it is. You all of you are right. It's not measles. Doctor, measles doesn't present like this. Measles doesn't have very important thing here. It's strawberry tongue. What else beside Kawasaki has strawberry tongue? Yes, scarlet fever also has strawberry tongue. Okay, so this can be confusing. Kawasaki disease or scarlet fever. You can think of strawberry tongue if you don't memorize whole mm, diagnostic criteria. But scarlet fever is because of post-streptococcal infection. There's pharyngitis, and after that, patient had strawberry tongue and this. Kawasaki, on the other hand, has very typical presentation, all of the which is mentioned in the question. Patient has 5-day history of high fever. Okay, very important because it's in the diagnostic criteria. Patient had 5-day history of high fever. Patient has conjunctiva. Conjunctiva is also very, very important that it should be non-purulent. Non-exudative or non-purulent conjunctiva is the diagnostic criteria of Kawasaki disease. Strawberry tongue is present, erythematous rash is present, cervical lymphadenopathy is present. Cervical lymphadenopathy can also be present in scarlet fever sometimes. So diagnosis is Kawasaki disease. Now we will finish Kawasaki disease because they give you 2-3 questions from Kawasaki disease, all of which is more different. Okay. Measles. Same doctor, which someone was saying measles. Measles have conjunctivitis. That is correct. But measles doesn't have strawberry tongue. Okay. According to whole this question, you should answer the question. Okay. Very important point here is that in measles, they will give you Koplik sport. I have seen recalls in which they have mentioned Koplik sport, a lot of other detail, but from Koplik sports, you can diagnose the measles. Okay, patient have cough and coryza. In this patient, you don't have cough, coryza, you have conjunctivitis. We are saying Koplik sport and 3 C's, cough, coryza, and conjunctivitis. This patient has limb involvement. This patient has difference from scarlet fever. Scarlet fever has, first of all, I have mentioned is uh, scarlet fever has sandpaper rash. Okay, this patient has what, erythematous rash. Other thing is that for scarlet fever you will have what, pharyngitis. Pharyngitis is present in most of the cases of scarlet fever. They will give you pharyngitis. Strawberry tongue is present. Cervical lymphadenopathy is not that common in scarlet fever as well. Okay, from this scenario, you can understand that this is not scarlet fever and this is Kawasaki disease. See, scarlet fever, we have sandpaper rash. It's very dry. Okay, they will mention it that patient has rash which feels dry, hard. Uh, Patient has pharyngitis or pharyngeal symptoms, and you will see the tongue. It will have strawberry tongue. Viral xanthema, it is an option, but it's not a specific term. Steven Johnson also has systemic toxicity, not like this patient. Okay, we can go from RCH. RCH has very nicely, okay, this is the Koplik spot in the measles, very diagnostic. See, these are present in buccal mucosa. Red spot seen in mucosa, it's of mouth, it's measles, okay? Also, they will give you cough, coryza, and conjunctivitis along with these Koplik spot or skin rash. Then you can diagnose measles. For the Kawasaki, this is from RCH. Let's go. Good 3CK. It's measles. Okay, we will finish Kawasaki disorder right now here, everything, because they are asking you either diagnosis of Kawasaki disorder or either treatment. There was multiple questions of the treatment of Kawasaki. Okay, here is the examination previous things. If you want to read, you can read. We will go for the examination or history. What we will do. For the diagnostic criteria, it is that fever must be persisting for 5 days. This is one of the diagnostic criteria, fever for 5 days, plus any of the four of the following. So a diagnosis earlier than 5 days can be made with a typical presentation in consultation with the experienced clinician. So they will not ask you, because you're a GP, they will not ask you this consultant level questions. Okay, just go that the patient will have 5 days fever, and after 5 days, four of the following criteria should be present. Another important thing, if patient has fever for 5 days, maybe one of these, but has coronary artery abnormality, then you will not think about that, oh, four of the five should be present. If coronary artery abnormalities are present, then you can diagnose it with Kawasaki disease. What are the diagnostic criteria? Diagnostic conjunctival injection, very, very important. They confuse you. Here, the questions in this question might have 2-3 lines, but their question is stamp is very extensive, so you might confuse it or you might skip it. Very important, it is non-exudative. It's not exudative, it's non-exudative or non-purulent, and it mostly bilateral. Okay, so just remember this. In conjunctivitis of Kawasaki disorder, it is bilateral, it is non-exudative, it can be painless. Limbic sparing, often with limbic sparing. Okay, remember it or not that important. Rash. What kind of rash they have? Erythematous polymorphous rash occurs within the first few days involving trunk and extremities. Variable presentation, most commonly maculopapular, erythema multiforme like scarliniform, bullous, vesicular, petechial rash are not typical in Kawasaki disorder. So just memorize what is important. Erythematous polymorphous. It can be maculopapular, it can be erythema multiforme. It is mostly on trunks and extremities, not on face. They didn't mention face. So most commonly it's trunk and extremities. Strawberry tongue. Strawberry tongue, you can see it is present here. Erythema, dryness, cracking of the lips can be seen like this patient. Extremity changes. A lot of time they are giving you these extremity changes and not strawberry tongue. Okay. Extremity changes include hyperemia. Even if patient has redness, like this patient has, it's just hyperemia. So this is a diagnostic criteria for Kawasaki. And painful edema of hands and feet that progress to desquamation from the second week of illness. After that, what will happen? Patient will have hyperemia, then painful edema, then it will lead to desquamation. Exactly this line was present in a past recall for the diagnostic of Kawasaki. They were saying that patient has hyperemia and edema, and the skin is desquaming, scaling, scaling skin is present. So this is extremity change in Kawasaki. Lymphadenopathy is cervical, most commonly unilateral, and it is tender. Okay, at least one node is more than 1.5 centimeter. Enough for you to memorize that cervical lymphadenopathy is present. It's unilateral. You have seen the pictures. They can give you these pictures as well. Other finding can be present are neurological. Patient is irritable, aseptic meningitis, abdominal pain, vomiting, diarrhea, asphalgia, arthritis. These can be present, but these are not diagnostic criteria. Inflammation at recent, within 6 months BCG vaccination site. This is also seen in a lot of Kawasaki patients. Very common. What is actually Kawasaki? Kawasaki disease is a medium vessel vasculopathy. Okay. Any organ can be affected because it's a vasculopathy. It's not a, it's just inflammation. It's not infection or anything like. I'm saying patient, for example, you have a patient, a baby, they had vaccination in last 3 months. Okay. Now they are presenting with symptoms of symptoms of Kawasaki. If you see a lot, I have seen a question, similar question in which they saw that patient had history of vaccination and now the point of vaccination is inflamed. Okay, that is BCG vaccination. BCG vaccination, if the inflammation of BCG vaccination, it's mostly seen in Kawasaki disorder. But patient should have within last 6 months, not beyond 6 months. For example, a baby present to you and you saw his BCG vaccination point and it's inflamed or has inflammation. This is also a seen in Kawasaki disorder. Okay, another thing is this is the typical diagnosis of Kawasaki disorder. We have another case scenario in which we call that patient incomplete Kawasaki disease or diagnosis is incomplete. What is this? That patient does not meet the full diagnostic criteria of Kawasaki disease. Okay. For this, we will see the flow chart. What is the flow chart here? Here you can see the diagnosis lead from here. Consider incomplete Kawasaki disease in a child with fever of at least 5 days combined with 2 or 3 of principal clinical features. There we were saying that 4 should be present out of 5, but here they are saying 2. If 2 or 3 are also present, but patient has fever for at least 5 days, consider this as incomplete Kawasaki disorder. Okay, an infant with one or more of the following features: fever is more than or equal to 7 days, but patient has irritability without other explanation, no explanation in an infant. Okay, prolonged fever and unexplained aseptic meningitis. This can also be diagnosed as incomplete Kawasaki. A child or infant with prolonged fever and shock, cervical adenitis not responsive to oral antibiotics. I don't think so. I have seen any recall from this incomplete Kawasaki disease, but it might come. So just remember it. Okay, see it once. Okay, incomplete Kawasaki disorder can present a significant diagnostic dilemma. However, once the diagnosis is made, the treatment for Kawasaki disorder and incomplete Kawasaki disease is identical. Treatment is same, but you should just diagnose the patient. Incomplete Kawasaki needs the diagnosis. Fever should be more than 5 days or equal to 5 days with two compatible criteria. Or fever should be in an infant more than 7 days without any other explanation. Then you will go with, if patient is presenting to you with this, then you will go with lab findings. Lab finding, you will check ESR and CRP. If ES and CRP low, okay, less than normal, or CRP is less than 30, ESR is less than 40. Then you will go serial clinical laboratory re-evaluation if fever persists. Echocardiogram if typical desquamation develops. See, I told you, in Kawasaki disorder, if we have coronary artery involvement, we will do ECG, echocardiogram. If we saw that there is coronary artery involvement, then we will diagnose that patient with Kawasaki disorder. We don't need any criteria. Fever with echocardiogram showing coronary artery involved. Here they are saying that you have this diagnosis criteria, but lab ESR and CRP are normal, and you follow up the patient. Either you will follow up the patient, or either if desquamation develops, you will do echocardiogram. And if in echocardiogram you saw coronary artery, diagnosis is Kawasaki disorder. Again, lab test ESR CRP if high, then you will go with other lab test. What is other lab test? And three or more of the following should be present. Anemia, platelet counts more than 450, albumin low, less than 30, raised ALT, WC, white cells more than 15,000, urine has more than 10 WBC, or abnormal echocardiogram. Among any of these you have, just treat the patient. I'm saying just memorize the typical diagnostic criteria of Kawasaki. And if you saw anything, patient has fever for more than 5 days and coronary artery involvement, diagnosis is Kawasaki. Go for the treatment. We have a long list of differential diagnoses. Very, very important point here that there is no specific diagnostic test for Kawasaki disease. That's why we have a whole diagnostic criteria for this. Okay. Another question that can come is when you will do echo for these patients. Echo is done with cardiology. They will specify the when you would do, but at presentation in 2 weeks or in 6 weeks. This is the recommendation. When patient is presenting to you, do echocardiogram. At 2 weeks in follow-up and at 6 weeks in follow-up, you will do the echocardiogram. Okay, before going for the treatment, does any one of you know what is the treatment of Kawasaki disorder or Kawasaki disease? Great mix of points, but yes, some of you are correct that this patient has aspirin and IVIG, immunoglobulins. Any information you guys have, you can write because everybody can read. Will increase their much. If cardiac involvement, then surgery until echo is done. Let's read now. Here, this again, I have mentioned this is from therapeutic guideline. So we have seen this also from John Murtagh. Okay, let's read from John Murtagh. It's very simple. John Murtagh has written Kawasaki is an uncommon but multi-system vasculitis. Very, very important. When you will go for pediatrics, I will tell you, just look at the ages. Ages are very, very important for a lot of disorders. Okay. So if you think, if they will give you a question, go for the age, because they will give you question for Kawasaki disorder that patient age will be less than under 5 years. Just when you are writing or making short notes, just remember Kawasaki is below 5 years commonly. Okay? It is characterized by, we have seen that fever is for more than 5 days. 4 out of these criteria should be present. Macular papular rash, mostly on trunk or genitalia, face, they haven't said involved. Bilateral non-purulent conjunctival infection, mucosal membrane changes such as strawberry tongue or cracked lips. Okay. Then we have peripheral changes of erythema of palms or soles, edema of the hands or feet, and at the end we have desquamation. Sometimes an unusual lapidash can also be present, which in history. Okay. Cervical lymphadenopathy, here they have mentioned 15 mm, it could be more than 1.5 centimeters, same thing. Usually unilateral, very important. That is this. So lymphadenopathy is unilateral. Single, non-purulent, and very painful. Any of these present? Coronary aneurysm also, if coronary aneurysm is also present, this is diagnostic. Again, they have mentioned diagnosis, a clinical one. There is no. Okay. In John Murdoch, what they have written that Kawasaki disease can be elusive as there are variations, which we saw that it could be incomplete. Then you will think, oh, it's very difficult disorder. For John Murdoch, they have simplified. They said, think of it in a miserable child with a high fever for more than or equal to 5 days. Okay, so you should have suspicion that patient has fever for more than or equal to 5 days and patient is ill. Then you will think about Kawasaki. For Kawasaki disease, we have nothing, no specific test. ESR CRP is usually raised because we have seen this is an inflammatory disorder. Thrombocytosis can be present, anemia can be present, abnormal LFT, hypoalbuminuria can be present. Okay, let's go for, this is important. This disease is generally benign and self-limiting. Okay? It is benign and self-limiting, but there is one important complication. The major complication is vasculitis. This vasculitis causes coronary aneurysm. That's why for diagnosis of Kawasaki disorder is very, very important. Okay? Because it will lead to ischemic heart disease and sudden death. This is the treatment mentioned in John Murdoch, that early treatment with IVIG, oral aspirin, and IV methylprednisolone has shown to be effective in reducing coronary artery abnormality. This is the patient. 2-year-old girl present with a 6-day history of persistent high fever. This is 6 day. On examination, she has bilateral non-purulent conjunctivitis, cracked lips with a strawberry tongue, as we have seen, polymorphous rash over her trunk, swelling of the hands and feet, a 2 centimeter unilateral cervical lymphedema. These all are the criteria for the Kawasaki disorder. Echocardiogram shows no coronary abnormality. Which of the following is the most appropriate immediate management? What is the immediate management? As you already said, all of you, IVIG and high dose aspirin. Okay, one of you doctors said about that before echo, I think you meant until echo is done, we will give supportive treatment. But in RCH or in either in John Matak, they have not mentioned. Yes, still aspirin. The treatment is IVIG and aspirin. Okay, plus aspirin, IVIG plus aspirin, they are giving. They have not mentioned that you will go with echo. Once the diagnosis of Kawasaki is made, you don't wait for patient to develop coronary symptoms or coronary aneurysm. You will give this to avoid this complication. The patient, it's not a necessary that patient will develop it because it's a complication. So for avoiding this complication, we will treat it with IVIG and aspirin. Okay, this is the Whole treatment which is mentioned in RCH. What is the treatment? You will give IVIG. Dosage, if you want to memorize, good for you. If you don't want to memorize, that's also good. No problem. IVIG should be given within the first days of illness, but should also be given to children diagnosed after 10 days if there is evidence of ongoing fever. IVIG should be given within first days. Very good. If you cannot, patient is not diagnosed within first days, after 10 days, also give this if patient has fever. Okay. So in short, just may remember that IVIG is given. Other thing is 3 to 5 milligram per kg orally as a daily dose until normal echo and follow. Okay, aspirin you are giving. You will follow up the patient. If patient has normal echo, then you will not stop the aspirin. Corticosteroid, evidence for indication in optimal dose duration of steroid in the primary treatment of it's limited. So it can be used, but it's not routine to give this. Okay, IVIG is given as single dose. Okay? It's not repeated or it's not continuous management. Single dose of IVIG is given 2 gram per kg. If first dose doesn't respond, then you can repeat the second dose as well. Or you can give it after 36 hours of the first IVIG. Just this much is important for you to remember. What is the diagnostic criteria for Kawasaki disorder and what is the treatment? IVIG should be given. Actually, they will not ask you first what is IVIG or aspirin because they have mentioned everywhere give aspirin and IVIG. But if we will go for RCH, RCH is mentioning IVIG first, then aspirin. So we can say that IVIG is the main treatment. If we want to see from therapeutic guidelines, this is from therapeutic guideline. If you can see here, management of Kawasaki disorder is IVIG, low dose aspirin if thrombosis is a feature, high dose aspirin as an inflammatory drug. So you can see there they have not mentioned that first you will give this and second you will give this. They are saying IVIG is also a treatment and aspirin is also a treatment. So both of them are given. Even in what I think past recalls also they are asking IVIG plus aspirin. I haven't seen a question they are asking separately. But if they are asking separately, I think you should mark IVIG. Again, it's similar, which we have already read. Other question they have asked is this follow-up of Kawasaki disorder. I already told you there is a previous recall in which they have asked about the echocardiogram follow-up. Follow-up is recommended at 2 weeks or 6 to 8 weeks. At the time of presentation, we are doing once echo. After that, for follow-up, do at 2 weeks and then after 6 weeks or 8 weeks. Okay, this is finished with. Okay, one of the doctor was saying not IV, no need of giving high dose aspirin. So if you can see in this in therapeutic guidelines, they have mentioned low dose is given if there is thrombocytosis. High dose is given if as an inflammatory drug, anti-inflammatory drug. So they are mentioning that give IVIG with high dose aspirin. This is what I have read. Okay, we have not much left, but this is very, very important. A 68-year-old man present with a recent episode of left-sided weakness and dysarthria lasting 30 minutes, which resolved spontaneously. History of hypertension and hyperlipidemia, both poorly controlled. Carotid Doppler ultrasound shows stenosis of 70%. of right internal carotid artery at the bifurcation. The most appropriate management. Let's see the most appropriate management. Okay. Okay. Mm, those of you who were not listening, now listen carefully because this question has many type of variations. Okay, so we can have different variations. Okay, and we will see when we are giving aspirin, when we are giving statins, when we are giving uh, endarterectomy, and when we are giving warfarin, or when we are adding something. Okay, because this question they are giving, I think every month. This is I have seen this question, but every time they are changing the question. So this question is very, very simple, very easy. If you will read it once, have read about carotid stenosis, very easy diagnosis that carotid Doppler shows 70% stenosis. In a patient who is symptomatic, just go with carotid endarterectomy. Very easy, simple, finished. Okay. This is mentioned in different articles, even in John Murtagh. John Murtagh is saying stenosis of more than or equal to 70%. Just go with carotid endarterectomy. It's this article. I will, because this article is very long, it's I think 4 or 5 pages. Just we will go with the important things which I will tell you. Okay. But if you cannot understand, if you want to go it completely, you want to know everything about it, just read it once. It's very, very good. Okay. I have mentioned the link here, but let's see what questions they are asking. Here, this is from therapeutic guideline, what they are writing that if patient presents with recent mild stroke or TIA, has a high grade ipsilated carotid stenosis. What is the high grade? More than or equal to 70%. Refer for urgent cardiac carotid endarterectomy. You will not do anything. You saw that patient has stenosis of more than or equal to 70%. Just refer him because it should be done within 2 weeks. Okay, within 2 weeks of the presentation of symptoms. Okay, because patient will have high risk of stroke. That's why within 2 weeks we will do endarterectomy. Then they are saying that below 50%, we don't recommend to go for surgery. Okay, between 50 to 69%. It depends upon the patient and it depends upon the surgeon what they make the decision for the surgery or for the endarterectomy. Mm, Here it's written benefit is marginal for patient with 50 to 69% symptomatic stenosis or when the surgery is delayed beyond 3 months. So when you have delayed it for 3 months, now the benefit is not as it was within 2 months, 2 weeks. Also for 50 to 69, I'm saying it's controversial. Someone are saying that we should do. Some are saying no, it has no benefit. But in therapeutic guideline, it's written that it's benefit is marginal. Okay. This is from John Murtagh. Easily, you can see that same thing they are writing that there is no evidence that surgery is appropriate for asymptomatic patient, nor for symptomatic patient with a stenosis less than 50%. If it's less than 50%, surgery is not recommended. If patient is asymptomatic, surgery is not recommended. But surgery for greater than 70%, yes. If it's more than 90%, refer just immediately. Patient should right now go to surgery. Okay, this is another point here that percutaneous transluminal angioplasty or stenting. It is done for, or it is reserved for those patients who are not suitable for carotid endarterectomy. They haven't asked question about this, so just keep in this mind that if you cannot do carotid endarterectomy, then you will go for stenting or angioplasty. This is the rule. 70 to 90% intervention. 50 to 69, it's a gray area, refer, it depends upon the patient and the surgeon. This is what John Murtagh is saying, but the articles, even RACGP have an article, they haven't mentioned that we should do surgery. It's not recommended in 50 to 69, less than 50% observed. Now, tell me if the patient has asymptomatic and has stenosis of more than or equal to 70%. Now, what will be your management? For this patient, we do endocrine. If he is symptom, then he very, very important. Asymptomatic patient needs, it's not recommended to do surgery. It's not recommended that patient has endarterectomy. 70% stenosis, yes, you may see that, oh, she has 70% stenosis, we will do endarterectomy, but no. Look what's written in John Murtagh. No evidence that surgery is appropriate for asymptomatic or for symptomatic less than 50. So they haven't mentioned with asymptomatic patient with this much stenosis, what to do. If it's asymptomatic, no need to do anything. It's not recommended. Okay, you will give what you will give medical treatment. You will give aspirin, you will give clopidogrel, you will give statins to these patients. No, it's saying that asymptomatic or symptomatic with less than 50. Okay, these are 2 points. If patient is asymptomatic, this is patient, she considered 2 patients. This is one patient by chance. Okay, you did carotid Doppler sonography. You saw this patient has a stenosis of 70%, but there is no symptoms, no weakness, no in TIA, we have sudden blindness, amoxis strokes. That patient has nothing. If this patient is presented to you, this is incidental finding on carotid Doppler. You saw patient has uh, asymptomatic patient with this 70% stenosis, but in these cases, you are not going to recommend her to do endarterectomy. This is what I'm saying. If patient is asymptomatic, then it's not recommended. We will give medical treatment, we will give aspirin, we will give statin. After that, in follow-up, maybe we don't need even, maybe this stenosis or this, mm, maybe it's a cholesterol plaque. Okay, it will resolve. So that's why they are saying that endarterectomy is not recommended. Okay, this the one of doctors asked about if asymptomatic but bilateral stenosis. This I will confirm it because I am think still we don't have any recommendation of endarterectomy, but let's go from the article. We will get the answer of this. Let's see, this is the question they are asking, confusing you like this. This is a typical recall. It's last year recall that patient has right-sided weakness. Question is asymptomatic with right-sided 50% and left-sided 70% stenosis. And what were the option? Anything you remember? We will see from the article. Let's see. We can get the answer from here. Wait. Okay. About this question, let's finish this because it's about all of this is about carotid stenosis. Then we can read the article. This patient has, this is a typical, this was a recall from last year. The patient had a right-sided weakness which resolved within 10 minutes. Doppler ultrasound showed 60% right side stenosis and 30% left side stenosis. Patient was already on aspirin. Now what to do? Okay, the option was, I will give you option because that's what I remember. Option was there, observe. Okay. Another option was do endarterectomy. Another option was add clopidogrel or Another option was change to warfarin. So what you will do for this patient? Yes, add clopidogrel. Now, same here, I will tell you another recall for what amount of time, for what duration clopidogrel and aspirin are given for dual therapy. Okay, this was an also recall because it's mentioned in TG. Yeah, 1 year is very long. It's not even 6 months. Okay, and I will tell you add clopidogrel. Very, very, very important. It's 3 weeks. Okay, this is from John Murdoch. What they are saying, antiplatelet therapy. It should be given aspirin. Aspirin is given, clopidogrel is given, or clopidogrel plus aspirin, or dipyridamole plus aspirin. They are saying it shows better outcome than aspirin alone. So these are the management medical treatment options, antiplatelet options you have. This is the topic which they are asking. Recent study have shown that the benefit of aspirin plus clopidogrel is greater in the first 3 weeks after a high-risk TIA or minor ischemic stroke. So a patient is coming to you with a TIA, symptoms of stroke, but they are resolving within 24 hours or even half an hour, 1 hour. They are resolved. Okay, patient is coming with this. Okay, what you will do, you will give aspirin and clopidogrel. If it is started within first 3 weeks, very high benefit patient has. After which time the bleeding risk of the dual therapy start to outweigh, diminishing the ongoing benefit. This is the recommendation that guidelines recommend that commence dual therapy within 24 hours and cease it at 3 weeks. After 3 weeks, you should not continue the this dual therapy. Start early, finish in 3 weeks. If you want to see the anticoagulation therapy, warfarin, when warfarin should be given. For warfarin, it's written for vertebrobasilar ischemia with increasing frequency of TIs. If patient has vertebrobasilar ischemia, if antiplatelet therapy has failed, that time you can give warfarin or use direct oral anticoagulants for non-valvular arterial fibrillation. If patient, we already know that in AF we are giving warfarin to the patient. So in that case, we can give warfarin. If patient had an arterial fibrillation at the age more than 65 years of age, then we can give warfarin even for TIA or stroke. Okay. Okay. This topic is finished. Let's go for this article. I will share with you this link so you can read as well. If try to search the answer for this question, that if we have, we will finish. No 10 minutes break. It's already switch to warfarin or use apixaban. This is what it's written in. Yes, why not? If it's, I've already told you, if they are saying that patient has vertebrobasilar ischemia, okay, they mention this, or patient has increasing frequency of TIAs. For example, if one patient presents with a symptom of TIA again and again, maybe 1 week, after 2 weeks, 3 weeks, that time you will give, or within a 1 month, patient has 2 times TIA. Next month, again, patient has 1 TIA. That time you will give warfarin because it has increasing frequency. Another meaning is that patient has failed antiplatelet therapy. For example, a patient comes to you with the symptoms of TIA. You prescribe aspirin, you prescribe clopidogrel. Both of them are started for the patient, but after 1 month, even on therapy, or on aspirin, on clopidogrel, you saw patient has again TIA or again symptoms of stroke. That time you consider that antiplatelet therapy has failed, you can start warfarin. And other cases, the cause of TIA or cause of stroke is atrial fibrillation, non-valvular atrial fibrillation. That time you will go with warfarin. If you have that question, if you have anything similar, because we can see from the stem what they are mentioning, so we can understand better. If I will find that question, then I will. With time, we will solve those questions if we can. See if you can open this link. I'm copy pasting, but it's you can search carotid artery stenosis and RACGP. You'll get the so you were saying patient has patient had bilateral stenosis, but both of these stenosis were less than patient was asymptomatic, right? See here it's written management of asymptomatic carotid artery stenosis. The commencement of best medical therapy is the main principle of treatment for asymptomatic disease. This includes antiplatelet therapy, statin therapy, cardiovascular risk modification. Aspirin monotherapy is the generally preferred one in asymptomatic diseases. Okay, sorry, I didn't tell you. I'm not reading for whole because we just wanted to answer about the asymptomatic. So I'm going directly to that part. Okay. Okay. Here it's written the role of surgery for asymptomatic disease continues to remain contentious in the vascular surgical community. The landmark studies supporting surgery for asymptomatic disease are the asymptomatic carotid atherosclerotic study, blah, blah. You see, they are saying even if patient has, they were considering that we should do surgery, but what happened? They think the efficacy of medical management has significantly increased, especially when considering the significant improvement in the management of hypertension, dyslipidemia, and diabetes mellitus. So if you control the risk factor, if you give the antiplatelet therapy, I don't think so you have to go for surgery in asymptomatic patient. Therefore, medical therapy alone is now considered by many to be increasingly comparable to surgical management for stroke risk prevention in asymptomatic disease. A reasonable approach from the general practice point of view is to refer asymptomatic patient with an stenosis of more than 80% for non-urgent vascular surgical review for consideration of surgery. So this could be your answer. This patient has If the patient has stenosis of more than 80%, even that patient is saying bilateral stenosis of more than 70%, that time you can say that they are saying still they are not advocating surgery. They are saying refer that patient for non-urgent surgery. It doesn't require that you should perform endarterectomy within 2 weeks. Okay. What I remembered from what I had studied, we also thought that this patient, even if bilateral carotid carotid stenosis is present, but patient is asymptomatic, then we will go with medical therapy, because there is nowhere it's written that patient with asymptomatic uh, carotid stenosis should undergo a surgery. Mm. Again, it's written that surgeon or their specialist referral, they will decide, they will see whether the decision for medical management is necessary or surgery is necessary after careful consideration of cumulative stroke reduction risk in the particular patient. Generally, patients who benefit most from the surgery are those who are young. See, it depends. Again, it will depend upon the patient. They are young, they have few comorbidities, then they will see what is the stroke risk reduction over their lifetime. Then we will consider that we will do surgery for this patient or not. But for overall, for patient, asymptomatic patient with ICS stenosis of less than 80%, referral is usually not required. These patients should have annual surveillance with ultrasound and monitor the progression of stenosis. In general, older patients benefit less from surgery as they will have an overall lower cumulative stroke reduction risk from surgery while also having higher potential complication rate. We know that if its patient is old, after surgery, the reduction of risk reduction of stroke will be less because they are old, they have multiple comorbidities, and we will add to them the complication of the surgery as well. So that's why they are saying for elderly patient, we don't recommend directly to go for surgery if patient is asymptomatic. If symptomatic, then we can. So this is what they have mentioned here. I tried to share this link, but I don't know why it's not coming. Simply just write. Uh, I tried 2, 3 times, but I'm copying it. When I paste, it comes like this. So if you want to read this article, you can search RSCGP carotid stenosis. RSCGP carotid. This is first article. This is the first article. If you search like this, it will still come. So you can read it if you want. So here we will finish. Thank you so much. If you have any other question, you can ask. But this is all from TIA and stroke. Okay, one more question I remember. There was one more last thing, then you can all rest. One question I remember, we had a previous recall also. In that question, that patient has symptoms of TIA. Patient was having hyperlipidemia as well, and other things, other comorbidities also. Then they said, what you will start for this patient? Their option was aspirin was there, but after aspirin, what you will give? Statins, because statins are more preferable. So you will give statins. Don't choose clopidogrel there if they have mentioned statin. Okay, this is also another question I saw, because statin is mentioned everywhere. Give statin. I think in that question, the patient was presenting, I think 2, 3 weeks later. That's why we will give statin. If they are coming within 24 hours, go with clopidogrel. Thank you so much. We'll see you tomorrow. Okay, bye bye. Allah Hafiz.